I'm Stacey Miller, physiotherapist and coordinator of the Child Health BC Hip Surveillance Program for children with cerebral palsy. I'm happy to be here today and share with you our experience in British Columbia of creating a population-based hip surveillance program. I'm speaking to you today from the traditional and unceded territories of the Coast Salish people, the Squamish, the Musqueam, and the Tsleil-Waututh, and I'm privileged to be able to live and to work in this beautiful part of the world that you'll know as Vancouver. I have no disclosures. So first, to set the context, British Columbia is Canada's westernmost province. We have a population of about 4.6 million people spread out over about 1 million square kilometers, with about 12% of the population living rurally. We have one hospital dedicated exclusively to children, and that's BC Children's Hospital, and it's depicted here on this map with a yellow star. In addition to the orthopedic surgeons that are at Children's Hospital, we have 4 orthopedic surgeons in the province that have a combined adult and pediatric caseload. Therapy services are offered in 35 child development centers and 59 school districts throughout the province. So our experience for hip surveillance really dates back to the mid-2000s when Kishore Malpuri, pediatric orthopedic surgeon and medical lead of our program, started his practice at BC Children's Hospital. And he became increasingly frustrated by the number of salvage hip procedures that he was doing. During an 18-month period in 2008-2009, 1 in 3 hip surgeries was a salvage procedure for a painful dislocated hip. And it was because of this that we went through a period of advocacy. And I describe this period of time as really being one in which we spoke to anybody that would listen to us. And so this included parent groups, physician and therapy colleagues, and hospital administrators. It's also a time when parents became strong advocates for system change. Because of this advocacy, in 2011, a meeting was facilitated by Child Health BC, which at the time was under the direction of Dr. Maureen O'Donnell, one of AACPDM's past presidents. And it's at this meeting that was attended by an interdisciplinary group with representation from across all regions of the province that we came to consensus that yes, surveillance was needed in British Columbia, and we developed our first set of guidelines on what that surveillance should look like. Just to note that our guidelines were updated in 2018, and so these are what we currently follow today. That group was brought back together about 9 months later and now asked to look at how we would implement those guidelines into practice. And so we offered different models on how we thought surveillance could possibly work, really designed around some key questions. So who's going to identify the child? Who's going to complete the clinical exam? Who's going to request imaging and measure migration percentage? And who's going to make sure that all of those things happen at the appropriate time? And at that meeting, we came to consensus that the appropriate model looks like this. And so this is what we actually do today based on the results of that meeting. And so we have physiotherapists across the province identify and enroll children in the program. That being said, anybody can identify a child and refer them to the program, but it's physiotherapists who identified themselves during that meeting as being the most appropriate for completing the clinical exam and enrolling children, given that they're already seeing them, they have relationships with the family, and they have the skills to complete the clinical exam. Imaging is completed in the child's home community, so as long as it's done in a hospital or healthcare setting, or sorry, a healthcare clinic, then we can view that imaging at BC Children's Hospital. And so it's our team at Children's Hospital that's responsible for ordering imaging, requesting the clinical exam, and when imaging is completed, to measure the migration percentage and report that back to the child's local healthcare team. We facilitate a referral to orthopedics if it's required, and work closely with those orthopedic surgeons outside of Children's Hospital. And so while that plan was put in place in January of 2012, it wasn't until September of 2014, through continued advocacy and a development of a business plan, that we secured funding for the program. And it wasn't until August of 2016 that we launched province-wide, so 5 years ago this summer. So as of the end of July of this year, we have enrolled 1,179 children in the program, and we continue to follow 828 of those. Unfortunately, we don't have an accurate number of how many children in the province have cerebral palsy, but based on our population and the prevalence rate of cerebral palsy, we estimate that we've enrolled 72% of children born between 2010 and 2019. Again, we don't have accurate numbers, but based on the literature and what we anticipate being the distribution of GMFCS levels amongst the population, we think that we've done a good job at finding most children that are at highest risk, so those in GMFCS levels 3, 4, and 5, and continue to have lower enrollment in ambulatory children at GMFCS levels 1 and 2. Throughout the program, we've asked therapists in the province to identify barriers that they've encountered when enrolling children in the program. And so one that's consistently come up is the lack of a cerebral palsy diagnosis. And we did anticipate this going into the program, and so we don't require children to have a confirmed diagnosis to be enrolled in the program. So when the clinical exam is completed, we ask that the diagnosis be provided, and you can check off cerebral palsy, possible cerebral palsy, not yet diagnosed, or other, and provide us with a diagnosis. And when we last reviewed that data, 25% of kids that are in the program were enrolled with an other diagnosis. And so we continue to work on CP diagnosis here in our province. The barrier that I found most interesting when getting these survey results was that it was reported that parents and family physicians or pediatricians were not supporting enrollment. And so this really gave us pause and made us think about why this may be the case. And so this led us to do some survey work of pediatricians in our province. We asked them similar questions to what we asked therapists and compared the results, recognizing that we had done a lot of education to therapists and relatively little to pediatricians. And so when we compare the results of the question, does hip displacement require standardized monitoring? Physiotherapists in our province were very supportive, and 85% very much agreed, versus pediatricians was half of the value of the therapy results. But I think what's more concerning for us was that when we asked if they were familiar with our program, 25% of pediatricians in our province were not at all familiar with the program versus 0% for therapists. And so certainly this made us realize that a therapist is going to provide education to children and families, who then take that to their pediatrician and ask questions about it. And if the pediatrician isn't aware of the need for hip surveillance and the importance of monitoring for hip displacement, then that can certainly become a barrier for hip enrollment in hip surveillance. We do see some regional differences in our ability to find children. And so this is our distribution by region. So we have 5 health regions in our province. And so you can see here that we're doing best at recruiting kids in the north, which if you'd asked me this when we started the program, if this would be the case 5 years later, I probably would not have thought that to be true. But if you look even more closely, let's look at the north, you can see here that there's actually a very significant difference in our ability to find even within the northern region. And so this really makes us consider too, is there specific ways of recruiting that we need to do based on where children are living? Radiology is always an important consideration when we're talking hip surveillance. And when we designed our program, we said that we were going to measure migration percentage. And we did this recognizing that we wanted children to be able to have imaging close to home. And the need to educate all the radiologists in the province was a bit daunting. But nevertheless, we wanted to look to see how well radiology reporting was done for those that were done for hip surveillance. And so when we reviewed this data last year, 70% of imaging was completed at Children's Hospital, and 30% was done at 64 different community facilities. When done at Children's Hospital, a little over 20% reported migration percentage, and in the community, only 3%. When it was done fairly well, if you want to consider the measurements that we do as the gold standard, but relatively rarely reported. We also looked more closely at the radiology reporting of images that were completed in community hospitals that resulted in a referral to orthopedics once we looked at them. And I think most concerning out of this is that 15% of those were stated as normal or unremarkable, despite the fact that the migration percentage was between 31% and 55%. And so I think the take home for this is, if you're going to be relying on radiology reporting for hip surveillance, education to those radiologists is going to be required. And so I started this presentation by noting that when we started our journey with hip surveillance, it was because we were doing a large number of salvage surgeries here at Children's Hospital. And I also talked then about how we did a period of advocacy and education and talking to anybody that would listen to us. And I think it's important to note here that we saw a significant improvement in the number of salvage surgeries just with that education that was provided. So in 2014, by the time, before we even started province-wide surveillance, we had reduced the frequency of salvage surgeries to 15%. And then since the time that the program has started, even early on in the program, it had been reduced even further to less than 4%. So lots can be accomplished just with providing education to the child's healthcare team and advocating for change. So just to summarize some of our lessons learned, I think it's important to recognize that implementation must be customized to your healthcare setting. And so what works for us in British Columbia is not necessarily what's going to work anywhere else, but important to be considerate of what existing strengths and resources you have and develop your program around those. I think it's very important for us to remember that hip surveillance is a multidisciplinary team effort, and that to have it become one team member's responsibility will make it much more challenging. It's important to remember that education is key for families and for the whole multidisciplinary team. And so again, just to reiterate that change can happen and improvement in outcomes can happen just with providing education and getting started. So there's no need to wait for population-based surveillance, but start now. Thank you.